hosted by the Academy of Pelvic Health in the United States and the United Kingdom-based Pelvic Obstetric and Gynecological Physiotherapy Network, known as the POGP. My name is Rebecca Seagraves, and I am a director on the Pregnancy and Postpartum Special Interest Group of the Academy of Pelvic Health. And I am pleased to be joined by my co-host, Grania Donnelly. Grania is an advanced physiotherapy practitioner from North Ireland and a full member of the Pelvic Obstetric and Gynecological Physiotherapy charitable body. Today, we will be revisiting our event that we held on February 13th of this year, 2022. Grania and I interviewed a panel of 11 physiotherapists from South Africa, the UK, Switzerland, Australia, Belgium, China, Spain, Canada, Latvia, and North Ireland on early therapeutic interventions within the first critical days to weeks after birth. Today, we will be speaking with several physiotherapists around the world who are committed to advancing maternal health before issues arise that need specialized and often limited care. We will be transitioning through topics that identify hospitals around the world that are providing the maternal population with physiotherapy within the first 24 to 48 hours after delivery. And we will be discussing interventions that are appropriate in the first 6 to 12 weeks after delivery to fully prepare individuals who want to return to running, sport, and other higher level activity after giving birth. At this time, I would like to bring our first invited speaker, Dr. Ann Krogan from the United States, to introduce herself, her practice, and the tremendous amount of work that she has done to advance fourth trimester care in maternity hospitals across the nation. Thank you, Ann.
Hi, I'm Ann Krogan. I'm going to share my screen. So I work in a rural setting in Colorado, and we came up with this idea to start having acute care see obstetrics in around 2014, and our program has grown exponentially. So I wanted to share just a few slides that I modified from a 2020 CSM presentation that I did with one of my coworkers. So why am I here and how did I get here and get really involved in this kind of advocacy work was because of the birth of babies. And my first child I had she was born via cesarean, and my recovery from that cesarean was not ideal. I was in a lot of pain and I had a lot of orthostatic intolerance, so I couldn't stand up. I ended up staying in the hospital longer than needed because I couldn't do any activities. I had to walk with a walker, so I couldn't carry a baby. And I kept asking if I could please have physical therapy come and help me. I'm an outpatient physical therapist who specializes in pelvic health, but I knew that acute care PTs could come in and help me move around the room and help me with my baby and all of these things before I was discharged home. But they had said, no, PTs don't come into the obstetric floor. And I just couldn't believe it. So I thought, well, we need to change that. And so I moved to this rural community that I live in now because I knew it was a place where I could start to facilitate a change. So one of the solutions that I came up with was, where does this acute care rehab even fit in? And we'll be talking about OTs as well. And one of the things that physical therapists are great at is recognition of risk factors. We're also really good at communication and care coordination and early intervention. So all of these things that acute care rehab professionals already did, I felt like really would work well with the acute care obstetrics program. So we did a Facebook survey back in 2019, and some of the things that are from this Facebook group that I run called OBPT, OB, OT, and PT was this is some of the reasons, like the barriers that they came up with, why we maybe would not be able to have PT in the acute care for obstetrics. And one of the biggest one was just this staffing shortage, and thinking about like physician support and different productivity implications. So these were, what they perceived were barriers. So all of these different pieces were there. So was there a gap in care? Like everybody thought, well, absolutely, there's a gap in care. Is it safe and feasible for acute care PTs to come in? Yes, they thought so. But could they come in for every patient? No. So this is where we start to see, like, there may be seeing the idea that it was good for cesareans, but not for everybody else. So these results really just looked at, like, currently nobody's really coming into the acute care obstetrics. No PTs are doing that really right now, that they go in infrequently. And that there is a need for it. So at least we recognize that there was a need for care. So this was our program. We started our program in 2014, and we started tracking our numbers really in 2016. So these were the number of women who we saw in the acute care who followed up in outpatient. And so you can see our numbers by 2019 grew by 61%, which is quite amazing. So we use this a lot when we're talking to other people about feasibility, like you wouldn't make money off of this. Well, each of these evals that showed up at our hospital, we made money in the outpatient for what even occurred in the acute care. This next slide is probably one of my favorites because I feel like it's the saddest one on what we were missing. So these are the things that we saw in our evals in the outpatient from the 2016 to 2019 timeframe. So pain was at that 77%. So that means, since I live in a rural community, there's nowhere else for women to go to for help. So we knew that prior to our program, these women were not receiving any help for any of these different impairments. And especially for the pain number, that's really disheartening that those women weren't getting any help. So I think that, like, when you look forward to creating a program in your own hospital, just the impact that it will have on your community is huge. Just to think that all of these women were having pain and it wasn't getting addressed until we started our program. And then patients were definitely satisfied with it. So we looked at, like, how do we better educate our acute care PTs? And so these are some of the things that we would do. We did one-on-one help. We did trainings with our acute care PTs. We did different checklists that they could follow. So there's a bunch of ways on how we put together our program, but I think the most important part was being patient. So we started in 2014 and it slowly grew. I need to run our numbers now for 2022, but we grew exponentially, and it took a lot of effort, and it took a lot of convincing of both the acute care staff and the physicians, but we didn't give up. So it's important not to give up, because they're going to tell you no sometimes. And so you just have to push through that and figure out a way around their no. So anyways, I wanted to share this slide too, because this shows just a couple of different hospitals at the time in 2020 that had started similar programs. And so these are larger bed hospitals. Since I'm in a rural community, it's easy to say that it will be easy for me because we don't have that many births per year. But if you look here at these 4 different hospitals, they have more births than we do, and they are able to do these types of programs. And then here's a lot of references if you want them. So anyways, that's just kind of our program in a nutshell. And I didn't know, Rebecca, if there was more that you wanted me to add.
Oh, so much more. And I'd never want you to leave. And I think the most pressing question, or even comment for people who are joining us and who will see this later, is a lot of times there's so much pushback because we have to recognize that anywhere around the world, our healthcare industry is an industry. it needs to sustain itself, and it needs to sustain itself financially. So the fact that you had data that showed that you were actually profitable for your outpatient pelvic health clinics, tell us a little bit about how you were able to convince the hospital team to allow you to start a program that may have been seen by people as being taking away from resources, or being a financial burden to patients or the system.
Right. I think it's such a good question, because I like to approach things when I talk to people as the right thing to do. And so sometimes I'm manipulative in my language for a reason. Like when I brought forth this program, luckily I was speaking to a female, and I think who had had a baby, and that made a difference because she understood that yes, women do need care in the acute care and postpartum. But I approached it as, this is the right thing to do. Women need services, they need help. And I tell my story, like I was sent home with a walker with orthostatic intolerance and told to like carry my baby around, like, and in pain. How am I not going to drop my baby? Like, so I think when you talk about it in that way, in a manipulative way of it's the right thing to do, it's super helpful. But also when you have people who don't understand that, I said, well, let's keep track of our data and let's see how much end up in the outpatient, because an outpatient evaluation charge, they make money off of that charge. And then they don't just come for that one visit. Depending on what their problem is, if it's pain, they're going to be coming for more visits. And so you're looking at least maybe 10 visits. And that covered that 45-minute time frame that inpatient PT had spent with them, hands down. So we made money off of that.
Incredible.
Yeah.
One important question that I want to draw Grania in on is that Grania worked with a team to bring forth the return to running postpartum guidelines that we use across the United States, United Kingdom, really probably across the world at this point, to really guide our moms who are athletes. They identify as athletes who want to return to this higher level activity after they give birth. And a lot of the argument around providing acute care or inpatient therapy services is to reduce symptoms, whether it's a diastasis recti, whether it's incontinence, prolapse. But I think we can also do well by focusing on improving someone's recovery for athletic performance, because we know that moms, they want to start running at 6 weeks, not 12. So what can you say to our audience now in the room with us and in the future who will be watching this? What can you say to convince them that offering care in the hospital this early would actually help moms get back to athletic performance like running?
I think it's really simple when we look at muscle activation, right? The sooner we can start getting that transversus activated, especially if they had a cesarean and they have swelling and that muscle's already inhibited. So if we can start isometrics immediately after surgery, no matter what surgery it is, we know that will help improve their outcomes later. And birth is no different. If you had a cesarean birth or if you had a vaginal birth, as soon as we can get those muscles activated, we know it'll improve muscle activation for your sport later.
Awesome. Thank you so much, Anne. Thank you so much for your share, for the work that you're doing, and really for inspiring people across the United States, really around the world, who want to start these services earlier in the hospital. Thank you.
Yeah.
To build on that, I actually think it's exactly what Anne's saying, because when you actually think about it, we're sending these moms home to do an element of physical activity, because that identity of a mom before they're even an athlete is quite physical. So I think we need to be showing them what they can do in that hospital setting, because suddenly they go outside the hospital realm, there's no support, and they've to fend for themselves. So you almost empower them from the get-go with that postpartum acute care.
It's true. And post-op, cesarean section is a major
you're right.
surgery.
Yeah.
And we're really talking about the heart of the matter, Grania, is mental health. Are we not?
Absolutely. It's that belief and that know-how, because I find it odd that this perinatal transition is one of few areas in healthcare that very little education, understanding, service support is provided to. So I always liken it to sports medicine, where I was going to say, I shouldn't stereotype, but a male footballer is going to get microscopic knee surgery and they get like 9 months rehab, done, dusted, guaranteed. And yet we have women who are going through a huge life change, role change, identity change, physical change, mental change, and we need to be setting them up better so that they can transition as smoothly as possible.
I agree. And I don't think you're stereotyping at all. I think that that is the case. That's absolutely the case. And that's why we're talking about this today.
Yeah.
Excellent. Well, I am excited to see on the other end of the world, in the UK, I'm going to actually invite our team from the UK that's been doing a tremendous amount of work to advance early fourth trimester care across the nation. I would like to bring up to the stage Suzanne Willisey, Jenny Shepard, and their teammate, Catherine Ross, will be joining us a little bit later, but please share the work that you've been doing with our audience today.
I'm going to actually just share a lovely presentation here, so just bear with me. And
hello, and thank you for asking us to be part of this event today. We're here to give an overview of the NHS England Perinatal Pelvic Health Project and our part in the implementation of this project as clinical leads for 2 out of the 14 early implementer sites for Lancashire and South Cumbria and for Frimley in England. I will start with an outline of the PPHS and then how we are implementing this in Lancashire and South Cumbria area, and then Jenny Shepard and Catherine Ross will present on how they are implementing the service in their early implementer site in Frimley. So to give some background context about the project, in the NHS England long-term plan in 2019, they'd stated that we are going to improve access to postnatal physiotherapy to support women who need it to recover from birth. And by 2023 to 24, we're going to ensure that all women have access to multidisciplinary pelvic health clinics and pathways across England via referral. In addition, the Independent Medicines and Medical Devices Safety Review in 2020 has stated that conservative measures must be offered to women before they have surgery, and that we've heard that specialist pelvic floor physiotherapy cannot match the current demand. The service commissioners should identify gaps in the workforce and a coordinated strategy that can then be developed to remedy this gap. And that was in July 2020. And it was fantastic at this point that there was such a focus on perinatal pelvic health and sustained funding to ensure these needs were to be met for women and birthing people in England. So the national service ambition was that the services will lead local delivery to improve prevention, identification and treatment of mild to moderate pelvic floor dysfunction following birth, and ultimately reduce the number of women living with pelvic floor dysfunction in England postnatally and later in life, and the associated personal, societal and financial costs. These are commonly known facts, but just to restate them about the importance of why our project is so important, 1 in 3 women will experience some form of bladder incontinence after childbirth, and 2/3 of women still reporting it 12 years later. 1 in 10 experiencing fecal incontinence, and 1/3 still reporting it 12 years later. And 1 in 12 experiencing pelvic organ prolapse. And that suggested shortcomings in both identification and treatment of pelvic floor dysfunction, and evidence had linked poor pelvic health with poor mental health postnatally. We know that physiotherapy is by far the most cost-effective intervention for prevention and treating mild to moderate incontinence and prolapse and other pelvic health problems. So we need to realise that pelvic health is including all bladder and bowel problems, pelvic floor dysfunction and perineal trauma, including obstetric anal sphincter injury, and also pelvic organ prolapse, dyspareunia and other pelvic pain syndromes. And as well as that, we've included within our service in Lancashire and South Cumbria all the obstetric pelvic musculoskeletal problems such as diastasis of recti abdominis muscles, pelvic girdle pain, back pain, and other musculoskeletal problems. So the bid process, this is the how the services are to roll out. So early implementer systems were started in 2021, rolling out towards 2023. We have that time to do that. And then the fast followers came on board this year in 2022 to 23. And then there'll be a national rollout of the project from 23 to 24. And that will roll out into nationally funded projects and workforce development with sustained funding alongside a service specification from April 2024. So this was our bid from Lancashire and South Cumbria. So in mid-December, they launched the bid process to become a project early implementer, and we had to submit by the 29th of January 2021. The bid was for recurrent investment to develop and expand the services. Pelvic health services in our region were very small and fragile, and they have very different services in all of our trusts with significant sustainability and workforce risks and challenges. It had been a problem for a long time, and it was wonderful that we could then address this. Our local maternity system submitted the bid, and we were the only successful bid in the north of England, and we were allocated funding to develop these services. The development of the bid was a partnership between allied health professionals, midwives, maternal mental health and consultants, and we established our multidisciplinary project team to deliver this programme of work across Lancashire and South Cumbria. And these are the early implementers. Here are we in Lancashire and South Cumbria, and these are the other early implementers across England who were awarded funding at that point. And then this is a more in-depth description of our area. These are the 4 different trusts that make up our area, and as you can see, it's a large area in the northwest of England. Then earlier this year, the fast followers came on board as well, and you can see that we've now got 15 fast followers who are also implementing this as well. So the local context, we have a large geographical area. It's about 18,000 square miles. We've got 1.8 million population with approximately 300,000 between 16 to 45 years. In the last year, there were nearly 17,000 births across Lancashire and South Cumbria. 17,000 births across Lancashire and South Cumbria. We have diverse communities with needs in geographical areas. We have 4 acute trusts and we have 10 hospitals. We've got East Lancs, we've got University Hospitals of Morecambe Bay, Lancashire Teaching Hospitals and Blackpool. We have 8 commissioning groups, and we've now combined into 1 integrated care board as of August this year, as well as having mental health and community trusts. We're in the top third of the most deprived areas in England. 13% of the population have fuel poverty and cannot heat their homes, well above the national average. 38% have childhood poverty, again above the national average. Our life expectancy in our region is 46.5 years. 40% have ill health linked with smoking, physical activity and obesity and substance misuse. We've got higher suicide rates than the national average and lower quality of life scores, and a higher incidence of long-term health conditions than the national average. Blackpool's the most deprived local authority in England, and some of our other regions are in the top 10% as well. And we have higher number of looked after children and a high rate of birth trauma and loss, which is impacting on both the health and mental health, and which of course are codependent. And that is hard for us then to raise the importance of pelvic health on that background of so many other health and social inequalities, but we were determined to do it. So this is our project group that we set up. This is our steering group. We got together and we started our early implementer project in June and July last year. So we have a senior responsible officer, we have a project manager, a clinical project lead, a midwifery lead, perinatal mental health lead. We have pelvic and women's health physios, consultants who are obstetricians and gynecologists, maternity voices partnerships who represent our service users and all of our women and birthing people, an integrated care system, senior responsible officer, some admin support and a digital transformation lead as well as part of our project. So these are the things that we have been doing locally. So we have data collection and audit to evaluate our service and inform our key performance indicators for NHS England. It's been really difficult to have that. That's been a real challenge, as we have different IT clinical systems with different data analysis capabilities across Lancashire and South Cumbria. We now have one maternity IT system, which is called Badgernet, which has helped in some aspect of our project plans, but IT and data collection continue to be a challenge for us. So workforce and recruitment. Skilled and trained pelvic health physios are really scarce and difficult before this project to recruit and to retain. So we had also, a part of one of our trusts, gone out to implement training posts to actually try and recruit and attract people to work in pelvic health. It's not part of the undergraduate syllabus, and physios get little experience in this specialism to encourage them to develop a career pathway in pelvic health. And we had successfully recruited in pelvic health in one of our trusts by having training posts, and we successfully rolled this model out across Lancashire and South Cumbria, which enabled us to recruit the newly created and funded posts to support the service. With pelvic health midwives, we're recruiting specialist pelvic midwives to support these midwife roles in pelvic health and have specialist clinics, as well as ongoing training and support for staff and clinical support for patients. And eventually we will be recruiting into advanced clinical practice roles for physiotherapists, which will support clinical expertise and career pathway in the specialist area. We're part of the pelvic health training and education. We have rolled out training programs for midwives, which are the Health Education England training programs, and Appeal, which is the antenatal preventative pelvic floor exercise and localization training, which we're hoping to make mandatory for all of our midwifery teams, so that they can raise that conversation about pelvic health, because midwives have most access to our women and can raise pelvic health at every contact with them, so that we can identify and signpost women to where they need to come. And we have pelvic health physios in training roles and posts, and we have put in extensive training and support courses, as well as having a clinical network to support peer support and mentor support for our newly qualified and training pelvic health physios. We're part of developing the pelvic health self-assessment tool. That's been developed with work from University of West England and Bristol Urological Institute to develop a self-assessment tool, and that will help facilitate early identification of pelvic health issues, and we're part of the team working with them to develop that. But we didn't want to wait for the development of a self-assessment tool, so as an interim measure we designed a risk assessment tool for both ante and postnatal patients to enable early identification and intervention for anybody with risk or symptoms of pelvic floor dysfunction. We have resources and we've collated an extensive high quality resources. We've agreed these via our Maternity Voices partnership groups. We have like an electronic library on our clinical maternity system that both patients and midwives or any health professional can take out of the library and send out to whoever needs it or wants to access it. And we send out prompts at booking at 27 weeks and postnatally, and that's just been implemented on our electronic systems currently. Midwives can access it at any point, and they form part of our pathway links and our risk assessment tool. And we're working with the NHS workstream to try and standardise all resources and patient information across England. Next parts, with 3 of our 4 trusts already had self-referral, but we're working towards this for all of our trusts, and that will aid accessibility to our services and empower service users. We have digital and other formats, but we still will have referral from other sources, from healthcare professionals, midwives, GPs, health visitors, consultants, all the usual routes. But we want to make it easy to use and access and promote our service so that people can easily access us. We've developed care pathways, which have been agreed by our multidisciplinary team and Maternity Voices partnerships for both pelvic floor dysfunction and obstetric MSK. And we have had very much a lot of involvement from our Maternity Voices partnerships, and we've had focus groups which have had physiotherapists attending pelvic health physios, and they've helped us review our plans and resources, and they've collated all our feedback to inform and influence our service both currently and going forward, and will continue to be a very valuable part of our steering group. And also we've implemented the OAC care bundle, One of our trusts is an official Centre for OAC2 study, but we've implemented the OAC Care Bundle at our other 3 sites with training and support with use of the Royal College of Obstetricians and Gynaecology resources. And we audit and record the use of the OAC Care Bundle on our Badgernet maternity system. And one of our measured KPIs is the OAC rate for NHS England. We've developed our multidisciplinary perineal and pelvic health clinics at all sites. The multidisciplinary, they form a single point of access to our service, and our care pathways sit alongside and are integral to these clinics. And as well as that, we're developing a comprehensive communication strategy, which involves social media, MVP groups, posters and leaflets, banners and QR codes, and prompts on Badgernet. And then we're going to have time for questions at the end, but if you have any future questions going forward, these are my contact details. I'm sure that Gráinne will be sharing, and APTA and POGP will be sharing the slides, but if you have any questions going forward, you're very, very welcome to contact us and discuss anything that you need to further to this session this evening. Thank you. And over to Jenny Shepherd and Catherine Ross, who will give a presentation of what they've been doing at Frimley. Thank you.
Thank you, Suzanne. I'm Catherine Ross, and together with Jenny, we are the project leads for the Frimley ICS Perinatal Pelvic Health Service, and we started our post back in May 2021. We from Frimley are a patch that covers several geographic counties out to the west of London. Some of you may have heard of Windsor Castle, which is in the north of our patch. Our population is diverse in terms of ethnicity and socioeconomic status, but we're very fortunate in our patch that we have one acute trust that serves the whole of our ICS patch. So that has made things significantly easier in terms of coordinating the rollout of these perinatal pelvic health services. You can see from the slide here that we have 9,000 births a year in our area, and that we have a population of 800,000. So to give you an idea of timings, we began in May 2021 and sought to engage with our stakeholders in order to co-produce our strategy. But before phasing in new ways of working, we spent a lot of time collaborating with maternity voice partnership service users, clinicians in our area, and then our initial rollout happened in January 2021 when we introduced our risk assessment tool. We also had to battle with a new electronic patient record system coming in across the summer, and for moving on now in our project, we're now looking at intrapartum care as well as evaluating our impact to date. So as a result of our stakeholder engagement, our focus groups, surveys and meetings that we had, we developed our perinatal pelvic health strategy. And here's an overview of some of the elements of the planned service developments that we have and we're going to tell you about today. So we created a series of web pages which included short advice videos within our maternity health and care website. This, alongside this, we've also developed a training programme from the maternity team, which is now running as part of their yearly update training. We've also completed training with our obstetric and gynaecology doctors, GPs, health visitors and mental health teams. And this has been a great way of raising the profile of the service across the system, encouraging them to make every contact count. So the resources are within the website. We have a range of resources dedicated to pelvic floor, exercise in the pregnancy period, and then exercise after pregnancy as well. We also felt that there was a need to prompt midwives to discuss pelvic health status and counsel for pelvic floor dysfunction. So we developed a pelvic health risk assessment tool that would be used at booking at 28 weeks and then at day 10 post-birth. And as a result of this, it then determined what level of resources to sort of highlight and target towards patients. So we used we developed this pelvic health risk assessment tool as we knew that midwives commonly use risk assessments anyway. They were using them for FGM, gestational diabetes. So we came up with the following risk assessment tool, and our focus group suggested that there was more time within the booking appointment to complete this. So we've got our initial one coming in then, and then in the day 10 post-birth appointment we have one as well. We've also introduced a 28-week appointment quick check-in on pelvic health as well. The development of the tool There's development of a national tool that's now underway, but it's not going to be ready until March 2024. So in the meantime, we looked at the best available evidence relating to risk, and following attendance at Taryn Hallen's Birth Choices training, we developed the tool. And then since then, the NICE guidelines have been published in December 2021, so we will look to update these at an appropriate time. So as a result of our risk assessment, we then stratified our resources dependent on risk. So if women are reviewed as to be low risk of pelvic floor dysfunction, they're signposted towards those range of resources that we developed on our website. If they have a medium risk of pelvic floor dysfunction but no current symptoms, then we are now running some pelvic floor workshops, which Jenny's going to tell you about. And then if they have symptoms of pelvic floor dysfunction, then they come through for consultation with a physiotherapist. Over to you, Jenny.
Thank you, Catherine. So yes, the workshops, we do antenatal or postnatal, or we have a perinatal recording, and they will inform women about their risk factors so that they can acknowledge them and do something about it, providing them some strategies and making informed choices about pelvic health and how it's been affected by pregnancy and birth. So we did start with virtual sessions and then have been gradually introducing in-person sessions across the patch. And our new physio assistant practitioner runs these sessions. And we created this hybrid role that combines traditional physiotherapy and maternity support worker skills into a hybrid post. And we did this jointly with maternity, practice development team, and union representatives. And we're hoping that, yes, they're going to provide holistic care, but also their visibility amongst the maternity team on the postnatal wards and running these community workshops will encourage better collaboration between our teams. And in future, they're going to be trained in infant feeding and possibly catheter care as well. Another aspect of our service is the introduction of a perinatal pelvic health service pathway within the general practitioner's system. We call it DXS. It's their decision aid system. So it's helping streamline the pathways, making sure women go to the right place at the right time, trying the conservative treatments first. So it can be there's quite thorough clinical governance processes that you have to go through to achieve this. And then we've been able to collect some data. So NHS England require 5% of deliveries represented in respondents to their surveys. We only started this from March 22, when the actual key performance indicators or outcome measures were agreed. And I thought perhaps I might share with you what the information we're getting at the moment. We feel like it's still a baseline, even though it came in a year on. But as you can see, 70% said they did not get the information about pelvic health and pelvic risks and pelvic floor exercises. And 57% also said they weren't asked if they had any problems themselves. So we're hoping that these will improve. At the moment, we need to really embed our survey within our new electronic patient record system in order to achieve representation. So we can see that 82% of the respondents are white and British. But at the moment, we have got a good spread of parity and mode of delivery, but we know there's a bit more work to do. But we're sharing these results at steering groups and training sessions because it can be quite powerful to encourage clinicians to make every contact count, but it is a team effort. And it's also helping us to evaluate our service. So we've noted that women like to receive information in a variety of ways. There isn't sort of one size fits all. And also that women are more likely to do their pelvic floor exercises in the postnatal period than the antenatal period. So we've got some more work to do in terms of getting that preventative training during pregnancy. So the next chapter of our service, we are looking at intrapartum care, as you mentioned, trying to minimise perineal trauma where possible and adhere to best practice guidance. And then continuing to monitor the success of our phase 1 with the data collection and looking at equality and diversity and access for all. And we have a number of ongoing challenges in terms of looking at space, our electronic patient record, recruitment, as Suzanne mentioned, that is a troublesome area across nationally. And yes, to keep the ongoing training and keep the promotion of the project. So yes, do get in touch if you have any feedback or queries about the project, or would like to, I think there's going to be questions at the end of the session, but otherwise, thank you all for listening.
Team, wow, thank you so much for that. I am bursting with questions. Grania, I think that I'll have to reel everyone in after that, because there's just so much work that you've done, and I'm so appreciative of you being here and sharing with our audience. The first thing that comes to mind, and I have to say this, is that just to kind of lay the foundation again for everyone in the room and for everyone who took in all of that information, to be clear, you set up programs where you're training OB physicians, midwives, physiotherapists on initiating these services as early as the first day or two after birth. Am I clear on that?
Yes, and from antenatally too. So, you know, right from the minute people are booking, even from a spin-off from this project, we're trying to do some work with teens and school children as well to get people before they're even pregnant. So yes, anybody we can get to at any point in their journey, in their life.
The very first question then I have for you, that everyone is probably like, especially in the United States, who's probably wondering, is how did you overcome the barriers? First of all, what were the barriers initially? If you can just kind of recap from your presentation so that we're all clear on that, and then how did you do it? Okay,
I can't see whose hands up to know who's putting the hand up to see whether Jenny's answering as well, but there always will be. One of our main barriers is, of course, it's the specialist training, the specialist physiotherapist. This is it's a very multidisciplinary project, reaching out, like you say, to all the different healthcare professionals. But we do have a paucity, we do have a scarcity of pelvic health physiotherapists, partly I think because it's not at an undergraduate syllabus level. So that's one of the things that we're working with higher institutes of education to try and get that back on the syllabus as well. But we've had to look inventively, I think, across the whole, because we're just 2 of the 14 early implementers, of ways of recruiting staff and encouraging them into the specialist profession, but just actually to get pelvic health, everybody talking about it. So, you know, lots of education, not only of healthcare professionals, but anything we can do through communications and banners and social media, anything we can do so that pelvic health really is on the agenda, that it's raised at every contact by everybody, but equally that people know, have easy access to our services as well. It's really hard if people don't know. They might recognise that they have a pelvic floor dysfunction problem. They might do a self-assessment tool, but it's then actually how do they access our services? So one of the barriers we've been trying to break down is actually making sure that people can access our services easily.
Excellent. And Suzanne, you mentioned the self-assessment tool, and I was so happy when you mentioned how you didn't wait for research necessarily. So you created a risk assessment, because we know, especially here in the United States, there's validity studies and there's so much time that it takes to make sure each question is really truly measuring what it's meant to measure. And that can take time. And so because of the obstacles that we have, and just what people would simply think, you know, is offer a physiotherapy visit in the hospital. Why is this so difficult? Well, we have to make sure that we're actually capturing the data that shows that this is a priority, that this is necessary, and it's not expending resources that we're already limited with. And so you created this risk assessment. First of all, is it available, you know, for us to at least see at some point, and maybe share, or is it still in the works of, you know, before you make it live for people around the world to at least see?
I can hand over to Jenny as well, because Jenny and Catherine have some extensive research
Yes.
and work on the risk assessment. I don't want to hold the conversation, but yes, of course, theirs is up and running. Ours is just being ratified by our maternity board, and then it'll be uploaded. But I'll let Jenny answer the question on the risk assessment. Sorry, I can't see the hand.
Jenny, please.
Sorry.
I'm here and happy to help.
Oh,
Can
you're
you hear
there,
me okay?
Catherine, as well.
Yeah.
Sorry.
Yes,
Okay.
thank you.
So our risk assessment, we knew that NHS England were going to put something together, and they're now doing that, and they're working with the Bristol Institute of Bristol Urology Institute to do that. I don't think I've got their name quite right, but they're the group that came up with the ICIQ short form and all of those forms. So it's the same group that are starting to work now on a. They're not working on a risk assessment as such. They're working on an outcome measure, a patient reported outcome tool. And so we put the risk assessment together because we trusted in our midwives to be able to ask the questions. So we kind of have given them the prompts around the things that they're looking for. So it's things like, have these women had a forceps delivery before? How many babies have they had? Did they have shoulder dystocia? How big were their babies? That kind of stuff. Have they got a family history of urinary incontinence or prolapse or fecal incontinence? So all things that we know are potential risk factors for pelvic floor dysfunction at some point in life. We decided to go ahead with that because we just thought it was going to take such a long time for it to come through the stages of being validated and everything. And that was going to mean that our project was just going to be so far behind the timescales. So we just went for it, really. I attended some training with Taryn Hallen. If you guys attend her training, she's from Australia, the WHTA, and I've done her birth choices course, and she talks, the whole course is basically about assessing for risk for pelvic floor dysfunction. So we sort of took that we were very up to, that was sort of, we did that just before we wrote the risk assessment. So we took everything that we knew from that, and then subsequently the NICE guidelines on pelvic floor dysfunction prevention and conservative management have come out. So we are going to do an update of our risk assessment, bringing it in line with those NICE guidelines, and then plus probably in a year's time, I'm guessing, maybe shorter. I think it's about a year time frame for the Bristol tool to come on board as well. We're happy to share it, but we do have to sort of give a caveat to that in the sense that it's not been validated by anybody, if you like, but it was a start point to be able to set our service up and give the midwives guidance on who were the people that they needed to identify for us. What we didn't want to do was set services up that were open to all, because what we've found historically is that the well-educated women just get more educated. They come and access those seminars and things, and they just get even more information. So we wanted to find a way of helping the midwives kind of target the women that really needed to be given that information. So that's why we put the risk assessment together.
Excellent, excellent. Thank you so much. And Jenny, just to end with you, if you can bring kind of us all together on this core issue, is what would you say to areas around the world who just cannot seem to get their programs up and running? What would you say is one thing that you would have us focus on in our respective areas to just, where should we start?
I think a good place to start, because perhaps particularly in England, but perhaps that's a shared thing, is that there's a lot of women that are midwives and women that are physios and social care. So when you're talking to the women about pelvic health, they're really interested, and then if they can get good at their pelvic health and their pelvic floor exercises and be informed, then they're much more likely to be ambassadors and mini champions across those. Start with them sowing the seed, and then hopefully if they become confident and tell more people, and then they will then make every contact count, like, oh, have you thought about your pelvic health? Oh, I know someone that can help you. Build from there. Start small.
Saying, so client driven, so have the person that's actually this care is being crafted for. You're saying have them be the ambassadors for receiving the care that they would benefit from in maternity care centers. Am I understanding you correctly?
A mixture. So I think it's just education. So I'm saying educate the staff, because then the staff, wherever they're working, in urology, in the nurses area, community, then they will be aware about their pelvic health as a staff member, because quite a lot of them are female. And then also, I think we should empower our women as well. That's why we've done quite a big social media drive, because then women are then asking the questions and volunteering the information. We know they don't do that. They're sort of putting their hand up, actually, I am wetting myself, or I have got bladder weakness, giving them some terms and knowing that there is something out there that can be done, so that they don't just sort of be quiet and live with it.
Excellent.
Can I throw in there at the end, Rebecca? Fantastic presentation from everyone, and thank you. It's really eye-opening to see the work that's going on. And as someone from the UK, not an early implementer site, would love the implementer sites to roll out. So we're really hanging on and hoping the evaluations fast track the rollout across the UK. But with that in mind, because there are sites and there will be people listening to this who are thinking, oh, we don't have that in our trust area. Are the resources and the QR codes that you put up, are they accessible to anyone throughout the UK? So like, could other regions use some of your resources that have been created for this?
So there's a work stream going on now with NHS England as part of this project to standardise all resources so that they're available across the whole of the NHS. So they'll be on the NHS website. But of course, that's accessible across the world. Anybody can access our website, you know, the patient forum. So there is, to come out of this, because we're early implementers, we get to have a go at everything and practice everything and see what's best and make mistakes as well. You know, you learn from your mistakes and what works. But it brings together all of the work that we're doing in the early implementers and first followers, that hopefully going forward will be not only nationally available, but, you know, for anybody to get hold of. And it will be standardized and high quality and reviewed and peer reviewed. And so it will get there eventually. And it's like, we're the early implementers, yes, and there are fast followers, but by 2024, the whole of this project, there will be a service specification and it will be rolled out across the whole of England. So, and then hopefully further afield as well. So we're just, we're the ones that, although sometimes they say never be first, it has done in this context been absolutely great to be first and actually have the resources to actually try and address pelvic health for all of our women and birthing people. So it's been great to be part of it, and also to work with other early implementers as well.
Yeah, at least it's putting it on the map, and it's putting the importance of it on the map so that other regions can look in and hopefully follow suit. So thank you for that and for all your hard work, and keep it up.
Yes, thank you so much. Thank you all.
Thank you.
Rebecca, where are we at now?
Rania, that I cannot contain my excitement. That is absolutely
love that
wonderful.
part. Yeah.
Oh my goodness. I cannot wait to see this modeled across the world, especially here in the United States, where, you know, our numbers really for maternal health and you know, the crises that we're seeing we're far past the time where we need something. So I think it's time really for a survey of at least our audience that's joining us in the room, and see if we can wake them up a little bit, because how do you transition from hospital acute care in the first few weeks to now getting someone back to running? So everyone, if you are live with us, Rania is going to pull up a survey and I will have her take it from here.
I am hoping that this survey is going to play. Yes, I think it's up on everyone's screen now, and I'm going
I can see it.
Great. So let me share it into the chat box for anyone who doesn't want to have to manually put in the code. So just bear with me, and don't panic if the survey has disappeared. I will sort it out in a second. I'm just going to put a comment into everyone's chat box, and hopefully this will be the right link. Let me see. No. So you may actually have to go to Mentimeter and put in the code 80125481. Bear with me because I'm going to see, I
am doing it myself. So that's Mentimeter or www.menti.com.
Yes. That hopefully might take it. I put a link into the chat.
All right, everyone, if you are here live with us, please, if you're watching later on, you know, obviously, you know, we won't be able to get your results, but still be thinking about this question. The question is, name one intervention that you can start in the first 6 weeks after birth to prepare for a postpartum return to running program. We emphasize running, but do know that other people like myself, we want to get back to bicycling. We want to get back to climbing. We want to get back to all kinds of activities. And we don't necessarily want to wait 6 weeks or 3 months to be given information that could have helped us ramp up and prepare for that time period. So as we all join who are live today on this survey, please do think about this question. And if you can, put it in the chat if you're not able to actually do the survey with us live. Go ahead and put your responses in the chat, and I see that they're starting. Excellent. Good job.
I love seeing everybody's different responses. I love seeing
I think it's awesome. This is truly awesome.
lots of pelvic floor coming in, lots of deep abdominal work, walking program. Yeah, getting functional. I love that. And
Yes.
here we've got our first mental health champion to that. Well done.
Yes. Mental
Body weight
health is
exercise.
so important, right? The mindset of an athlete. You have to restore that mindset when so much has been put on hold during the last trimester of pregnancy, even through the first quarter after birth. So huge. Diaphragmatic breathing, that's getting bigger. What does that mean, Grania?
Diaphragmatic breathing. So
Yeah,
that's
when it's big,
really,
when it's big like that, what does
oh,
that mean?
when it's big like that, it just means that it is important and it's picking it out.
Oh, wait. So that means that more people are saying diaphragmatic breathing when it's big like that.
Possibly, or there might be individual things. It's just the way that it's picking them out, but and it
Oh,
might change at some point. But I'm looking now as it's getting as there's getting more text. I'm looking to keep
I
track of
love
what else
it.
is coming. Down training,
Yeah.
I love that. So down training of perhaps abdominals or pelvic
Mm.
floor muscle, depending on how someone is responding. Because I think one of the big things that will come out of today too is that postpartum care is individual. It depends on different people's needs. There is no one size fits all.
Grania, you're right. Wait, so down training, can't that even be for someone after a cesarean section who's like, in pain and guarded for weeks at a time?
Absolutely. Yeah.
Right. Grania, there are some things in the chat. So people who are not able to actually contribute to the Mentimeter in front of us are writing in the chat, pressure management from Gianna Granger, Gail Brook, walking, that's a huge one. It's so simple, but just actually teaching someone how to stand up tall, not be hunched over in the first week is absolutely important to prepare them for running. Breath work, I'm seeing rest for healing. Absolutely rest. How many moms go without sleep?
Oh, I know. And I'm looking also even seeing absolutely scar mobilization, because if that scar is healing, people may start to then, if it's at the stage where it's healed, people may start to mobilize at it, which is absolutely correct. And that could happen within the first 6 weeks.
Someone mentioned nutrition. I mean, how do you address this, Grania, with your clients before you actually get them up and running again? Nutrition as a
Yeah,
physio.
I think the awareness, I always think that I very much stay within my lane because I'm not a nutritionist, but I think
Cool.
common sense advice about and giving people the understanding that if their body is recovering, they need all the building blocks that we need for recovery and for tissue healing. So it's getting them to be more mindful about what they're eating and are they getting a wide variety of the nutrients that they need and the fluids that they need. But it's always given them that permission to ask their surrounding village that, if someone's saying, what can I do for you? Get them to make you nutritious meals, because as a postpartum woman, who has time to be starting to think about how to make nutritious meals? You need to call in your village of support.
I agree. Oh, this is much. Someone wrote too much, too much in terms of one intervention that you could start in the first 6 weeks. Too much, but not overwhelming, right? Because all of this, I believe, and Grania, tell me if I'm wrong, but I believe that if we actually provide this information early enough, it won't be overwhelming, right? Recovery
Yeah.
on your own is overwhelming. Doing this on your own is overwhelming. By yourself is overwhelming. But this information to me would be actually taking away a lot of the stress. What do you think?
I totally agree with you. I think informed care makes everything better. I think when we understand something and understand even the changes that are going to happen to our body through pregnancy, through that transition from childbirth into motherhood, I think that it can do a lot to firstly decrease fear, because fear is something that really inhibits recovery in any context, whether we're talking about an injury or whether we're talking about childbirth. I think giving people information and empowering them is exactly what they need. And I love that someone wrote in about giving a risk assessment in the first 6 weeks, and it fits in with what we've just heard about from the early implementer sites. And I suppose identifying risks and flagging up who needs to go for individualized one-to-one rehabilitation care. And that's really important in those first 6 weeks, to picking that up and not waiting until the 6 to 8 week GP check.
It's so true. In the first 6 weeks, at least in the United States, Grania, 57% or more of our mothers are perishing in the first 6 weeks from issues related to preeclampsia, other hypertensive disorders, cardiac arrest. And so to me, a physiotherapist in those first 6 weeks would be the ideal provider to catch anything that's a red flag for someone who's doing a little bit more activity than they should, especially if they're a single mom and they have other kids at home.
And I think too, in these first 6 weeks, society that we now live in at large, so for any of us who are accessing things like social media, there's a really false impression of what postpartum looks like put out there. It's this snapback culture, and that's where I think a lot of pressure goes on to new moms, where they don't know how to navigate this. They want to get back to a certain activity and they don't know exactly how to get there, so they put pressure on themselves because they see social influencers doing X, Y, or Z. And so I think it's really important, as you say, that we give them the education and information that they need.
Excellent. Well, Grania, you are not off the hook. I cannot wait for you to give us the nitty-gritty about your actual guidelines, your return to running postpartum guidelines that you worked and put a tremendous amount of effort with the team that you partnered with to make these come about. So please, without further ado, don't keep us waiting too long. So I will allow you to share your screen and I will come back on for questions and engagement after.
Okay, I am going to, hopefully this is, oh no, I'm going to unshare that because I did it wrong. Bear with me, guys.
Not a problem. So everyone who is joining us today, Grania is going to actually cover the actual postpartum return to running guidelines that we were just encouraged and educated about to prepare moms early after birth through the first 12 weeks. Take it away, Grania.
So everyone, I hope you can see me okay. This is a bit weird. I'm in the presentation and bear with me because my rights and lefts are all wrong. But I wanted to keep it a little bit more conversational and I wanted it to be less text and I wanted to get into the nitty gritty of the discussion because I'm actually going to lend to postpartum return to activity and sport in general. A lot of the work I've done has been in the context of running, but I think it's easily applicable to any sort of exertional or a high impact sport. And we're going to discuss a little bit about that as we go along. I do welcome discussion, so please get chatting in the text box. Rebecca will be keeping an eye on that and she can bring it all together at the end. So we've talked a lot about the early care postpartum and the importance of it. But oftentimes I think that people jump into this minefield of what happens after early care and how exactly do we support our women to navigate their way back to the type of activities they want to do in life, whether that is running, whether that is CrossFit, whether that is weightlifting, whatever. And as we all know, there's a lot of conflicting information out there on the internet, and there has been a significant lack of focus on this area and on this population until very recently. It's only really within the last decade that the shift of focus has changed to where we're now actually investigating perinatal women and perinatal athletes, which is fantastic. But like everything, it takes time and it takes time for knowledge translation to get into practice. So while I'm going to start navigating this chat, I want you to start writing in any sort of concerns, worries, or questions you have about postpartum return to activity, or what are the things that you're finding conflicting out there at the minute. Because really that's the reason that the return to running guidelines that Rebecca mentioned came about. We got frustrated in clinical practice and it was myself, Emma Brockwell and Tom Goom, who's actually a musculoskeletal physiotherapist. We came together to put something out there to be the starting point for some form of guidance to support women in navigating this journey. And it was because there was no significant or no official guidelines out there. What turned out, I'm sorry, I'm admitting people as I'm doing this. What started off as just a simple fact sheet soon turned into what was more in the form of a guideline, and we self-released that almost as a white paper. And we probably didn't expect there to be the response that there would be, but they essentially went quite viral because people, both the women themselves and health and fitness professionals, were hungry for this information. One of the things that we have found with the research that we've begun to do since the guidelines came out is that fear, and I'm actually see that I'm covering words there, just wait till I move off the line, worry, lack of guidance, one of the biggest things within this population is that there's a huge fear of movement postpartum, probably because of all the conflicting information and probably because of the lack of official, robust, streamlined guidance. And this is quite interesting because until we carried out a study, which I'll be showing in the next slide, on postpartum women investigating the multidisciplinary biopsychosocial factors impacting returning to running, fear avoidance behaviours were largely associated with sports medicine and return to play after things like anterior cruciate ligament injuries. So we never really thought of postpartum women like this. But as Rebecca mentioned at the beginning, just because we're in a population now that's perinatal and becoming mothers doesn't mean that we still aren't athletes or physically active women or women who are looking to get back to a certain hobby or activity. So we need to start breaking down the silos of care between the likes of sports medicine and pelvic health and perinatal health. And we need to start, I suppose, thinking about them in the same way. This is the study I mentioned. This was led by Dr. Izzy Moore from Cardiff Metropolitan University, and it was a survey that went out to 881 women. Really interesting to find out that the average running time for people returning to running after having a baby was 12 weeks, and this totally ticked my biases in terms of it fit with what we had put out in the returning to running guidance. And we also found that a lot of the things women were experiencing included things that we would expect, such as there was musculoskeletal pain, particularly lower limbs. But there's also almost a third of women were leaking, which fits with our understanding of general population urinary incontinence. What became really interesting when we analysed our findings was that it wasn't really urinary incontinence that stopped women from running. So we're presuming people were happy enough to pad up and run on. But it was things like vaginal heaviness. So this really highlighted to us the need to screen beyond urinary incontinence. We need to make sure that we're screening for all symptoms that can present in terms of pelvic floor dysfunction. So we need to be screening for symptoms of prolapse, symptoms of pelvic pain, sexual dysfunction, and not just incontinence, but also voiding dysfunction, fecal incontinence, defecatory disorders. So that was really interesting. The key positive findings that we were able to identify were that women who ran during pregnancy were more likely to return to running after pregnancy. And this is fantastic news, as I suppose exercise professionals, as people who really endorse physical activity. It's really positive to see that physical activity during pregnancy is not demonstrated as being harmful here. So women who are medically fit, who were able to continue running, increased their odds of returning afterwards. And it was this study that we identified postpartum women as showing behaviours in a fear avoidance model. So it's really important that we're picking up on that, because fear avoidance behaviours hinder progress and rehabilitation. So what exercises do we do then? Where do we start and what do they look like? Physiotherapists, I think, traditionally tend to like protocols and prescriptive type approaches, but the more research we do and the more we understand and start to really look at things within a biopsychosocial context, the more we realize that there is no one size fits all, and that each woman is as individual as the next. And everyone's baseline is going to be different, because if someone's entered their pregnancy as an elite athlete, their return to activity journey may look slightly different to someone who had a really poor physical activity baseline before pregnancy. So we need to look at it all in context. We need to look at the person in front of us, but most importantly, we need to look at their goals, because what activity is it that they want to get back to? So while a lot of the research I've been involved in has involved returning to running postpartum, I can't inflict my bias on people and think that every woman postpartum wants to run, because some women hate running. So we need to really focus in on what type of activities that particular woman is looking to get back to and facilitating it. And there is no such thing as a bad exercise that they can't get back to. So we see a lot of mixed things on the internet about certain types of sports or activities being not ideal for postpartum women. And the reality of it is that we are really robust. We are made to get pregnant, navigate it, enter into childbirth and come out of it. And if you think of the lifestyle of a mother, it's quite a physical activity and challenge anyway. And I believe that we can get people back to anything they want to do. Again, to break down those silos and start to think about sports medicine, I do think that we have to apply sports medicine principles. And there are things like specificity, overload, progression, but also things like load tolerance. So how are we thinking about those tissues? Are we respecting that postpartum tissue healing? We've mentioned about the early rehab that's important and getting early intervention. How has that went for a woman? Because if someone's coming into clinic and they've had a really smooth recovery, had vaginal delivery, no stitches, no problems since, really enjoying it, good village of support at home, that's going to be very different for someone coming in at the same time scale postpartum who had a wound infection or a breakdown of a wound, or perhaps they were readmitted with sepsis. So they're going to be in two very different starting positions, where one person's rehab's ready to progress on and the other person we may be stepping back a little bit before and getting the basics right before we progress onwards. And one of the things I'm really passionate about encouraging at all stages postpartum, so whether you meet someone 6 weeks down the line or whether you meet them 6 months or a year for the first time, it's going over the important education on pelvic floor function training that was highlighted by the girls earlier, and making sure that people are training adequately. One of my pet peeves is that I think that the pelvic floor is chronically undertrained, and by that I have no doubt that women are getting the information about pelvic floor training, but I don't think we're training it adequately. I think that a lot of women think that Kegels are just easy wee flicks that they do, and they can do them, and they often come in and say, I've been doing my training and they don't work. And when you ask them how many maybe pelvic floor exercises they think they can do, you know, I might ask them, do you think you could do 8 to 12 repetitions? They're like, oh, yes, I could do 50 or 60. And that already tells me they're not recruiting to max voluntary contraction. Because again, if we think of the principles of sports medicine and muscle training, we need to be training into that max voluntary capacity in order to get changes in the muscle tissues. And I also think of it, I always explain to women, if they were doing personal training sessions, so everyone can usually relate to that idea of having a personal training session at some stage in their life. Maybe it was coming up to a wedding or something. And I always say, if you were doing biceps curls and you were given a weight, would your personal trainer just say to you, do it until you get tired and then stop? No, they would probably get you to keep going on and doing a few more reps through that fatigue zone. And it's tough and you want to stop, but that's how you get change. And pelvic floor training needs to be the same, particularly after we've been through significant changes like pregnancy and particularly vaginal childbirth, where that area has been stretched so much. We want to get muscle hypertrophy to start to get that muscle bulk supporting the base of that pelvic outlet again. So I think it's really, really important, and we need to train both types, so the slow endurance holds. But for those fast fibers, which often are the ones that we see, I suppose, fail us and things, if we leak with a cough or sneeze or sudden movement or raise our voice, we need to be training with really ballistic, rapid type trainings nearly spontaneously. So throughout the day, I would nearly tell a woman that she needs to be doing a really rapid, fast, full pelvic floor contraction in order to get those fibers really engaged and initiated. I was delighted to see this paper come out. Actually, it was only come out in the last week, and this was by Christina Previtt and team, and it identified that experienced weightlifters, all these women were people who lifted beforehand, but women who were weightlifting, who continued weightlifting during their pregnancy, including supine weightlifting, they had no negative birth outcomes, and in fact they demonstrated benefits compared to their peers. So this was a really, really interesting survey-based study. It helps to, I suppose, give us more robust information and understanding that women are robust, that we don't need to be as cautious as we have in the past. And oftentimes a lot of our cautions around physical activity during pregnancy was based on the fact that we didn't have studies and investigations to test concepts out. But this was fantastic, but it just does need to be noted that this was on a population of women who are already experienced at weightlifting. It's open access. I've put the link in the DOI down there, and maybe someone might share that into the chat box, but it's a really, really nice paper. And again, it's more empowering information, and actually all these women who were weightlifting during pregnancy got back to weightlifting afterwards, which is again another positive outcome. So for context of returning to activity postpartum, so we're working towards, say, whether it's running, whether it's CrossFit, whether it's Taekwondo, whatever we want to get back to. I want to first lay the idea that we need to consider that woman within her day-to-day life and what she's going to be doing. And that needs to fit around rehab as well, because there's no point us scaling women back and giving them supine heel slides and telling them they can't do deadlifts or squats or lifting if their day looks like deadlift, squats and lifting anyway. So women are often doing farmers carries all day long because they've got shopping bags that they're carrying in. They're often got a child in one arm and a pram in the other. Their squats, lunges, deadlifts throughout their day. So I think that we need to be grading up these types of activities in the rehabilitation programs in the build up to returning to full function. And again, depending on individual recovery, if someone's recovering well, I do think we can start things before the 6 weeks. We can start to do these sort of activities, maybe without weights, first of all, just doing the movements of deadlifts, doing body weight, sort of gentle squats, thinking about and letting that woman be her own guide as to how she feels, how her body's telling her whether she's tolerating that, whether she's symptomatic or not. Because again, if we start to introduce an activity postpartum and a woman experiences any signs of pelvic floor dysfunction, whether that's incontinence, pain, feeling of heaviness or pressure, that's a symptom telling us that she's not managing the load that's been put in that area and there's more training needs there. So like we would do in any other area of rehabilitation, we would scale back and we would grade up in a way that she's tolerating, or we'd modify in terms of the number of reps or the volume of that activity. So there's different ways that we can modify it to make it ideally symptom free and keep her progressing on. But again, it needs to look like what she wants to do, and it needs to factor in the type of activity she's doing all day, every day. So these are two infographics that were produced based on the return to running guidelines that Rebecca mentioned. And these were probably the key for things going quite viral, in that, you know, infographics are easy things to look at. They tell you information at a glance, which people like because it's, you know, the convenience of our life. We're all busy. And they also give people a taster of information that made them want to go and get more and look at the full document. The first infographic that you can see there, I can't even do it, that you can see there is like a clinical reasoning tool. So these guidelines were not meant to be prescriptive or used as a prescription. And while they are a graded approach with exercise suggestions at each of the time scales postpartum, they were not meant to be a one size fits all, and you're meant to clinically reason where someone fits into that. So like I mentioned earlier, if someone's coming who has had lots of medical complications after having a baby versus someone who came in who's had a really straightforward time and they're coming to see us at 4 weeks postpartum, one of them might be ready for that, what we're suggesting at the 4-week time scale. The other person might be back in weeks 0 to 2, and that's where you as a rehabilitation specialist clinically reason and decide. But the key thing is that it's not just about the physical recovery. As you can see in the clinical reasoning infographic, the first one, the objective screening involves wider biopsychosocial considerations such as psychological well-being, sleep, things like body mass, relative energy deficiency in sport. Like, how often do we consider that within the population of postpartum women? We often think of it as a sports related condition, but relative energy deficiency in sport really means when the energy output exceeds the energy created. And postpartum women are at high risk of this because we have a population who are sleep deprived, perhaps eating on the go, maybe feeding everybody else and grazing themselves and not realizing that they're not getting their own nutritional needs. We have a population who may be feeling some compromise to their mental health and postpartum depression. And basically, there's a high risk of them entering that deficit, especially if they're feeling the pressures to get back to physical activity, or perhaps they're pre-partum self and they may be throwing themselves into physical activity and exercise. So please be aware of looking out for this, because relative energy deficiency in sport can have really negative consequences to our overall health and well-being, including impact on our menstrual health. It can affect our bone density, and you'll often find that women with relative energy deficiency in sport may be predisposed to things like stress fractures. So we often find runners get like a 5th metatarsal stress fracture in their foot, or we have had some pelvic fractures as well. So please be aware of that and look out for it. The other thing I'd like to point out in the second infographic is that we have in the weeks 0 to 2, the kind of activities that we were talking about that came up in the word graph for things that you can do in those early postpartum days and what a lot of the early implementer sites talked about. So pelvic floor training, walking, very basic activities, start getting functional again. And while we put it in 0 to 2, we meant that anything in that level, you can start it at that stage postpartum and you continue it on. So pelvic floor training, walking, all these activities carry throughout the postpartum phase. It's just about when they're introduced, because I do think that it can be quite confusing. It can look that we're just saying people only need to do 2 weeks of training, and that's not how it was meant. But as you can see, it's a graded progression within a biopsychosocial context. And this is the same approach we use with return to sport following injury. And really, I think there's a lot of crossover clinical reasoning there that I'm looking for people to call into action. Interestingly, I wanted to highlight the work carried out by Shaw et al. Now, both these, Shaw et al., and I can't see what the other citation there is at the top, I've text covering it, but they're the same research group. Basically, it's just a different author first. They did a lot of research on intra-abdominal pressure during different activities. And I think this is really interesting because one of our concerns with postpartum progression of exercise is that we might overload women too soon. We might overload the pelvic floor or the abdominal wall. And with this, we can become very restrictive in our rehabilitation approaches. But the work of Shaw et al. Was really interesting because they highlighted that there wasn't really any activities that matched up to the same level of intra-abdominal pressure as the seated strain. So when they got someone seated doing a Valsalva, the amount of pressure picked up within a vaginal pelvic floor sensor was highest during that seated strain. And when they then looked at women with the same sensor in when running, lifting, sit-ups, jumping, yes, they were the higher intra-abdominal activities out of all of them, but they were nowhere near the seated strain. So that's the first context I want to put into play there, that sometimes I think we think these activities are so harmful and damaging when I suppose when we start to view them in this context, they're nowhere near a Valsalva or strain. But what the studies also showed was that there was variability in intra-abdominal pressure amongst individuals during the same activity. So it depended on their baseline and it depended on the type of activities they were conditioned to. But some women during the same activity showed much more intra-abdominal pressure than other women. And this highlights it or takes us back to why we need to be considering the individual and not throwing out blanket rules or exercise prescription. So I think it's really, really useful. And I think it's another reason why we can appreciate that women who ran during pregnancy were more likely to return to running. Women who lifted during pregnancy were more likely to return to weightlifting. We're starting to see this trend. And perhaps we need to be really, I suppose, evidence-based and informed when it comes to our exercise prescription during pregnancy so that we're not limiting people and deconditioning them during pregnancy, because they, from day one, postpartum, as a mom, are going to have a baby to lift and they're going to have activities to do no matter what mode they delivered by. So we need to start preparing women to be physically capable for this. And I suppose the trends, and I keep reinforcing it, but where each person is as individual as the next, just like all these flowers in this bunch. And the clinical commentary that we put out in the special edition last year, we spoke about it during the first round of the first trimester care, and when Sinead talked about the different studies within it. But this is the infographic from it. And I do call anyone who hasn't read that paper to check it out, because this is really a paper that's a call to action for the actual implementation of a biopsychosocial approach. So not just lip service to it. Sometimes I think that without thinking we are giving lip service to it, we can ask a few questions that are biopsychosocial related in our subjective screening, and that almost ticks that box. And then we can get on to being physios and looking at the physical aspect. Whereas I'm trying to highlight that the biopsychosocial model and all the considerations we have should carry through the entire assessment and through our treatment and reevaluations. And what we found was that things like how much someone deconditions during their pregnancy, what their body mass was like, you know, whether they've any postpartum thyroid issues, all these factors impact their readiness for scaling up physical activity postpartum. But actually these factors impacted each other as well. So like postpartum fatigue and thyroid issues has implications for our musculoskeletal system. It causes widespread joint pains. It can also have implications on our tissue healing and recovery. Same for sleep. And we already understood factors like this in terms of sports medicine. So I bring it back again to our knowledge within the sports medicine context, whereby sleep is really important in terms of injury prevention and injury recovery. So why wouldn't we be thinking about it in the context of the postpartum woman? But also things like breastfeeding and debunking common myths. Like, you know, a lot of women are told that breastfeeding, you know, and they blame relaxing as being the culprit for making all their ligaments and tissues loose, whereas we know that it's likely a hormonally altered environment of multiple hormones, but also the fact that there's not all women who are breastfeeding have any sort of issues in terms of their joint laxity, and there's other factors that probably come into play here, such as their baseline joint laxity and whether they have any hypermobility symptoms, and just other factors that are going on in their life. One of the ones I really want to highlight is that socioeconomic considerations, because this is one I think that isn't considered enough. Don't assume when women are coming to you that they know the basics of public health messaging. So some women have had huge difficulties or never actually accessed things about the importance of physical activity, the basics of pelvic floor rehab, anything to do with exercise prescription. So you may be the first person seeing them. You may also be the first person to pick up signs of pelvic floor dysfunction and send them where they need to go. So I do think it's a really, really important one. And I love the fact that we heard from the early implementer sites earlier, because they're starting to provide an equal platform of access to all, which is really, really important. And building on from our return to running guidelines, we wanted to, I suppose, speak to the athlete population too, because a lot of our guidance and a lot of the research coming out on our physical activity guidelines are targeted to the general population, and they're targeted to the like types of activity levels that the general population engage in. But what about our population of women transitioning into motherhood who, as a baseline, have super high levels of physical activity and exertion? I suppose general population guidance doesn't really lend to them, because they maybe are already doing higher levels of activity than what's guided in it. So we wanted to put out a specific return to sport framework for them, and it's the 6 R's framework: ready, review, restore, recondition, return, and refine. And the key thing about this return to sport framework is that, unlike sports injuries, when we may not know when we're going to get injured, pregnancy and childbirth gives us a huge opportunity to prepare. We can anticipate the upcoming physical, physiological, psychological changes, and we can put plans in place. Rebecca spoke about the need for empowering women with information, arming them with the information, and how that might change their care and their approach to that recovery stage. And I think this is really true, and we can get women in those early stages and we can start to implement that, and that's going to only have a positive impact if we think about it. So I'd like to give a shout out to my co-authors, Roz Cook, Emma Brockwell, Izzy Moore, and Alan Rankin, who helped create this paper. And again, if you haven't seen it, look it up. It's published in BGSM, and it's a really interesting read. But the thing underpinning it is that it's the safety of both the mother and baby at each step of this framework. So not just the ready stage when the baby is in the mummy's tummy, but we also have to be thinking about the baby's best interests and safety in the postpartum phase of life too. And so how we manage and address a woman's postpartum recovery has the care of the baby in mind as well. I'd like to also say that we've just this week released an expert statement, a BASIS expert statement. It's called A Bump in the Road, the BASIS expert statement on pregnant and postnatal athletes. So this is another call to action for organisations to implement support and policy for women who are transitioning into motherhood and looking to continue their performance careers. It's open access. You can get that on the BASIS website if you look at the BASIS website and go to expert statements, but it's been a fantastic initiative to be part of, and I'm really delighted. I'd also like to shout out that I see that our colleagues in the USA, a lot of you are probably already aware, but at the upcoming APTSCSM, we have Amanda Olson, Sandra Gallagher, Rita Deering, and Shefali Christopher carrying out a workshop on evaluation of the postpartum runner. So if you want to learn about their 4-step approach and really get into the nitty-gritty of the things you need to consider, this would be something really useful to tune into. So great to see that featuring. And we only just found out this week that we have a publication accepted into Current Sports Medicine Report. So this is what I have published this as a result of, I spoke at AMSSM, the American Society of Sports Medicine Conference in April, and following it I was invited to publish something into it for their sports medicine physicians and general practitioners, and I jumped at the chance. So they wanted something on sports medicine and the pelvic floor, and I took my pelvic health and expertise and the research I've been involved in, and I drew in Dr. Izzy Moore, who's a sports medicine specialist, and we put together basically information, giving an overview of what people need to be considering. So stay tuned, that will be coming out soon. And in keeping with bridging the gap between sports medicine and pelvic health, something that I'm really passionate about investigating is not just the guidance that we need to give to women, not just about flag and pelvic floor dysfunction and telling them to go get help to rehabilitate it, but what sort of things can we do while women are waiting to rehabilitate their pelvic floor? How can we help them? So one of the things I've began investigating, and I started it as my part of my master's in advancing practice, which I've just finished. I did a feasibility study using compression garments targeted to the pelvic floor, and we knew that these compression garments had lots of subjective data around them in terms of the benefits of them. So there was lots of surveys demonstrating benefits in reducing urinary incontinence and pelvic organ prolapse. There was studies done in the local universities. So that was great, but I wanted to investigate, was this just simply placebo, that people have this idea they're wearing something, so we reduce the fear, which is positive. There's nothing wrong with that. But I wanted to see, was there any objective implications for the pelvic floor? And I suppose I got thinking about this because I give kudos to Professor Paul Hodges, who describes the pelvic floor like a trampoline, and he talked in an ICS podcast. It's their first ever ICS podcast. If you go onto the website, he talked about the need for a balance between mobility and stability at the pelvic floor, and Paul likened the pelvic floor to a trampoline, whereby when load's placed upon it, it needs to be able to absorb that load before giving back. So the pelvic floor isn't too stiff and rigid, it isn't too loose, it just has the right level of stiffness to do what it needs to do. And this is important because we know that women who have urinary incontinence oftentimes have urethral hypermobility, so they have lack of support at that anterior vaginal wall, perhaps as a result of childbirth, perhaps other factors such as chronic constipation, weight gain, different things. But when we have that lack of support at the anterior vaginal wall, activities that increase our abdominal pressure tend to cause that bladder to go down. You can see this in this illustration I've drawn, where you can see the bladder neck height, and you can see an activity that causes exertion, and you can see that bladder neck drop. And I started to think, could compression garments add an element of stiffness to women, whereby they're getting a little bit more support and maybe they're not getting all of that load, having that impact as much? Now, my feasibility study was underpowered, which we knew it was probably going to be, actually. It was a master's level study, so I was limited in how many I could recruit, but it was underpowered, and so it didn't show any significance in terms of bladder neck height for women wearing compression garments versus not wearing them. But what it did do, when I looked at bladder neck descent instead of bladder neck height, so looked at the difference between women at rest in terms of the bladder neck height and on Valsalva, women wearing the compression garments had less descent than women not, and 50% of these in particular. And when I looked at the 50% who had a significant, or not a significant, but had obvious difference, because I was just doing descriptive trends in this, they were more likely to have had a vaginal delivery and also have a wider levator hiatus. So it's got me thinking about this even more, and I'm going to explore this concept more in obviously powered studies and in a variety of ways, so stay tuned. But I do think that there's some room for us to break down those silos between pelvic health and sports medicine even further, because we've lots of research on males investigating muscle recovery in lower limb compression garments after they play. So why are we not investigating women who go through things like abdominal surgeries and vaginal deliveries and huge significant changes during pregnancy, and then are feeling the demands of motherhood afterwards? We need to be applying time and investigating this population, because if we can find adjuncts that facilitate them, that can help, I suppose, get them back into physical activity earlier, perhaps. And it can also, who knows, down the line, serve as some form of preventative support. So we don't consider going and engaging in physical activity without a sports bra, but we have areas of the body that are essentially a bottomless cavity that we rely on the muscular support for. And if that's compromised after we go through huge significant changes like pregnancy and childbirth, then should we not be thinking of supporting this area better? Stay tuned. So now I want to throw it to everyone and see what you've been thinking about as I've been talking. I always think when you're presenting on Zoom, you feel like you're presenting to yourself because I can't see anyone else, but hopefully there's still people there. Hopefully it's got you thinking, and I'm really keen to hear what you're thinking about. What do you think needs to happen to facilitate that return to higher level activity? And where do we go from here? I'm going to stop sharing my screen. I'm going to call Rebecca back in. And I'm going to look at the chat too.
Oh, I have been on fire. Rania, every time I hear you speak, first of all, I'm coming back on, everyone. Every time I hear you speak, I get beside myself. That was so good.
Stop.
I'm serious. Oh my God, especially about compression. I'm a lymphedema therapist. And so when you were talking about, facilitate, interventions early on that could actually facilitate our muscle function, especially around the pelvic floor. We're pelvic health therapists, most of us who are watching this presentation. And so when you're thinking of facilitating all that circulation that is really, giving into gravity at this time of recovery, and saying that that could possibly help function weeks, months down the road, I'm all ears. So the chat has been on fire. I don't think I would spend time looking at it. I need to
talk to you then, because you need to bring your lymphedema expertise to me and inform my PhD, because I am investigating this. So I want to make sure I'm considering all elements and not getting tunnel vision. So this is great. We'll speak about this after.
Well, absolutely. I mean, this is why we did a part 2. For people who didn't join us in February of this year, this is why we started such a tremendous shift towards, revisiting this topic over and over again, because there's so much research. When we talk about evidence-based, there not being enough to support our interventions, I think we just need to do more in terms of research and really get into these interventions and see if they're actually working in this population when we know they work for athletic populations. We just need to see this population as the athletes that they are.
Yeah, absolutely. Yeah. Love that. So what have I missed in the chat, Rebecca?
All right. Well, I'm not further. We have only a few minutes with these folks. Okay. So I'm actually going to bring some people to the stage who said, okay, I have questions. Yes. Let's go ahead and actually invite another director on the Pregnancy and Postpartum Special Interest Group, who's also a runner, who also sees moms within the first few weeks after birth. Dr. April Douglas is joining us today, and she wanted to give some perspectives and also ask questions from the athlete point of view that really fits with what you were saying. Well, what could we do early on to prepare them for running and other activity? April, come up and join us. Thank you.
Thanks so much. First of all, love your work and use it every day.
Oh, thank you.
So appreciate you and thank you so much. One of the huge barriers that I've seen with a lot of my specific runners and high level athletes, I think the general population is so thankful and grateful for the information and the guidance and tend to do really, really well with them. When we get to the higher level, where it's people that are semi-pro and pro athlete runners, Olympic level, we get the high level, they rely so heavily upon their sport for mental health. And also, they're just used to their body functioning how they want it to function. What have you found that's been helpful to pull in the reins a little bit on some stuff, as well as what can we push on the thresholds with them? Because I find myself just constantly holding them back and pushing more strength training, and that's not enough for them. So what is your advice?
So I'm going to have a twofold part to this answer and say, first of all, if you're really evaluating and considering that people aren't ready for the, say, high impact or really high load or exertional activity that they're just dying to get back to. We have to make the rehabilitation look as close to it as possible. And there's ways we can do that. We can, lower weights if it's a weight-based exercise or activity. But even things like those people who are dying to get back to running, things like I call it a stairmaster, or is it elliptical or whatever, something that makes them feel like they're getting a real big lower limb workout. They can still get their breath up and things, but it's maybe lower impact. Or with our runners, we tend to think uphill or incline running being less impact than on the straight or downhill running. So it may be that we'd be clever and be like, right, you can do hill runs, listen to your body, arm them with the information that they need to know when they're having overload of tissues, but tell them that they can run or jog up it, walk down, run or jog up. So they've nearly interval type training. But the other thing is that in the clinical commentary, which I actually meant to speak about, so I'm glad you asked this, in the clinical commentary that I put up in the presentation, we had a supplementary file with 2 case scenarios. And so we wanted to give that, I suppose, understanding of how we maybe go through that clinical reasoning process. And unfortunately, as we all know, clinical practice is not a lab setting where we have really controlled environments and we've controlled criteria of people turning up. It's individual settings with variations in environments that change on a daily basis or minute to minute. So we put 2 examples of people who, and we highlighted the pros and cons for people to return into the type of activity they wanted to get back to, which in this context was running. So what we find is that I like to do risk benefit analysis and think of it as a seesaw. So I'm going, right, the throwbacks of them going back at the stage of this, the benefits are this, and seeing what way it tips. Okay. So yes, someone mightn't have the ideal number of weeks that we consider tissue healing needs to take place, but you may weigh up that their mental health's going to really take a hit if they're not getting to the type of activity they want. Do you know what? Actually, running will be really good for managing that postpartum weight gain that they have, because one of the things we know too is while the focus shouldn't be on weight loss, that normal weight gain we have during pregnancy, if we lose it within the first 6 months, I think 6 to 12 months anyway, it's in the clinical commentary, we have good predictive indications of someone's risk for long-term obesity. So we're supposed to put on a certain amount of weight gain during pregnancy, which is normal, but we should be able to lose it afterwards. So you're thinking about different factors that may be beneficial, and even thinking you might decide that someone's having really poor sleep, but we know that physical activity helps sleep. So it's basically a risk benefit analysis like we would do for return to play in sport. And I always think if we can take it back to the same reasoning and think, right, nothing absolutely life-threatening is going to happen here. I've armed them with the information about pelvic floor dysfunction, what might happen, how they might set themselves back, and take an informed and educated decision together. And therefore, you're kind of empowering the athlete. But as long as they know what could happen, and if they overload too soon, it's the same as injury context. If they end up with an injury, they're going to set themselves back. They might do the same if they overload too soon postpartum. And I think we can make a really useful judgment. But if you're absolutely scaling them back, make the rehab look as close to what they want to get. So another example I have is I had someone who wanted to get back to CrossFit toes to bar, and they're really, really, really looking to get back to it. So again, they wanted to do elements that look like that. So initially we had them in I suppose earlier than when I wanted them doing toes to bar, they were doing like knees to chest, but they were hanging. So they felt like they're doing it. It felt like their sport. So that's the type of approach I would take.
Thank you.
What else do we have, Rebecca? Who else are you bringing in?
Absolutely. Thank you so much, April, for asking that question. I actually have another director on the pregnancy and postpartum special interest group who's an ultra runner.
Oh,
And
love it.
yeah, I mean, her perspective, I think, is just so valuable. She and a team have worked so hard, Grania, to really, off of your guide, your return to running guide, make it, accessible and translatable, the research that you've done to the practitioners who are on the ground, who don't know how to actually transition our clients early enough to get them actually on the ground at 12 weeks when it's appropriate, and not at 4 weeks or 6 weeks when it's too soon. So I'm going to call up to the stage Stacey Head, who's with us. She's floating around. I'm trying to look through our room to actually find her. So I found her. I'm bringing you up, Stacy. Thank you so much.
Because I literally have 3 screens right now in front of me. So like, if I'm looking the wrong way, that it's only because that's where you guys are.
That's okay.
Not a problem. Look straight
I
ahead.
was like,
Look
me do
straight
my
ahead.
presentation. I'm like this.
Exactly.
Thank you, Stacy, for joining us. Please share a little bit about your background, ultra running, and the resources you've developed.
Yeah, so I've been an endurance athlete well before I had my son, starting with marathons. I've done Ironman. It's actually only since I had my son that I've actually got into ultra running. And I put in the comment box a little while ago, I realized it came up this year on Facebook in my memories that I started running 4 weeks postpartum. And I was sitting there and I was like, oh my God. Like, I was like, where was this information back then? My son's 11. So, you know, it was like, what do you feel? How do you feel? Do what you do. And now though I would be like, I would never have done that. Like, I don't know that I was ready.
Well, what was the experience like though? Like when you look back, was there any negative side effects, or were you actually okay?
I have a rectocele.
Okay.
From delivery, my son was a preemie, so he was early, he was small. I had no tearing or any issues with delivery. So in general, I feel like my son was in the NICU for 6 weeks in a hospital that was not the same one as I delivered in. So I was home and he was in the hospital. So some mental health stuff, but physically, I feel like that allowed my physical healing actually happen a lot better because I got some pretty decent sleep for the first like 2 weeks while he was in the NICU. And you know, who knows whether if he hadn't been there and he had been home, whether my recovery would have looked the same, right? So, but as I said, I got back at 4 weeks. I did have one run that I went out with, and I don't know where it was in that time frame where I felt prolapse. I was like, I feel like there's something between my legs, and I turned around and I went back. I ended up, I think, calling my OB and going to see them, and they were like, oh no, you're fine. And I'm like, oh no, I'm not. And because they tested me in a supine position, and in a supine laying down position, my prolapse looked fine. But when I got up and I exerted, it was not. As I said, he's 11 now, like 11 and a half. So I have learned how personally to manage my prolapse. And I would say 99% of the time I am asymptomatic. But at the same point, I mean, look at what we do. So hopefully we know how to learn how to manage our bodies, whether it's with nutrition, hydration, you know, for me with rectocele, with good bowel management, you know, so I don't have constipation and things. That's when, honestly, that's the 1%, is usually when I'm traveling and my nutrition, my hydration may not be on key, or in this time, you know, I've had some minor injuries that have kept me maybe from running as much, and running usually helps me stay regular as well. So, but, you know, without knowing that, I think it's really challenging. But I really am like excited by all this stuff, like, especially when you guys came out with like in, what was it, 2019, with you and Goom and the study, and like that, I was like, oh my God, I am so happy. And I've really used a lot of that. And actually, Shafali Christopher worked here at Duke, where I work. I work at Duke now. She's up the road. But so I've worked with her and talked with her a lot. I see her actually at local triathlons, and we have like coffee discussions pre-race about stuff like this. But I've been working really hard based on some of your information, some of her stuff coming together, and trying to really just set up screenings. So we did our first one about 2 weeks ago, where myself and 2 other therapists for 4 hours on a morning just offered 1 hour free in-clinic assessments to anyone who was postpartum. And you know, that could be a big range, because people are like, where do I have to be postpartum? And we tried to put it at 6 weeks, just because if they were before that, we were like, you might not be able to do as much as we want you to be able to do for return to run or return to stress-related injuries or stress-related activities like high impact lifting or things like that. But, we had, not as many people as I would have liked, but I think we had a great turnout. But along with that, a lot of our physicians realized, and not just our like OBGYNs, but our orthopedic doctors who are maybe seeing these women 6 months to a year after, maybe because they have a hip issue, right? But maybe, and I see this a lot in my practice, because obviously I don't necessarily see hip issues, but I see that person who maybe has a hip issue, but it's not getting better. And maybe they're a year postpartum. And I have to say, I think it's really good that we have a lot of therapists within our program that are orthopedic therapists that know, like, we've educated a lot on pelvic floor stuff. So like if they have some ortho patients that aren't making progress, that they may send them to us for something else. But
Stacey, I have a question in terms of the 6 week, and Grania, if you can respond to this in terms of that like 6 week where she's starting, I think that that's absolutely appropriate. Would you add to any of that, like just information or a handout that can be given to those individuals before 6 weeks, before that they would start, doing this regimen that Stacey's describing?
I think the sooner we can get the information to women, the better, even as a plan, because a lot of what we talked about, even in the previous question, was trying to keep people back. But if they can see education, understand the plan, and understand that it's going to progress to where they want to be, sometimes the race to get there can slow down because they're like, okay, I'm going to get back there. There's a process in place.
So like a handout, like they can still use the handout that Stacey's and her team has created, but not necessarily act on it too soon.
Yeah, and just get ideas and get familiar with it. And it's funny because it got me thinking when you were talking about when the 2019 guideline came out, like, again, we probably took a bit of a jump with doing that because technically, like, we extrapolated a lot of the evidence base that existed because there was very little on the population that we wanted to guide. And we also used a lot of expert consensus. But if we were to wait to the true process of creating an officially produced peer-reviewed scientific guideline, we'd be waiting still. But life isn't waiting. And it's kind of like what the early implementer site discussed about that risk form that they created, that it's not through the process yet, but they put something out there. Absolutely, because we're not in a control lab. We're living life, and we need some guidance that we can then improve upon when we get more robust information and go, all right, we didn't have it quite right with that, but we'll refine it. So I think that's where it's really important. And one of my huge passions is bridging the gap between academia and clinical practice, because I never probably thought I would be getting into research. I was also always identified as a clinician. And then it was my pure frustration and putting a call for research out there to then being invited to be part of that research that got me kind of thinking, well, it's really important that clinicians are involved, because actually in the multidisciplinary biopsychosocial study that we put out that demonstrated fear of movement and vaginal heaviness, it was only because me and Emma, the two clinicians on it, were saying, but this is what we need to ask. This is what women tell us. It wasn't on their radar because pelvic floor dysfunction in I suppose, people who have not been in clinical practice, because there was so little awareness of this area, it often stopped at urinary incontinence. And we were like, no, we need to ask beyond this. So that's why I'm really passionate about clinicians getting involved in research and informing.
I agree.
I think I veered off the question.
Stacey, stick around. I want to bring back this full circle. We started out talking about acute, environment and things that we can do in the hospital setting, at home, and then right to what Stacey's doing, in our outpatient population, and getting them right back to actually running. I want to bring in an acute care therapist that is actually working with these moms who are our outliers. We still, in America, at least in the United States, we have a third of our population that's delivering by C-section. They want to return to running too. they need those guidelines too, but they need a very individualized, and Grania, you talked about this a lot, an individualized care approach. And so I want to bring this back full circle to everyone in the room and invite Elizabeth Compton, it goes by Beth Compton, to the stage to just share, if you can, what you do 24, 48 hours after birth, and what you believe this really does to bridge the gap for this population.
Can you guys hear me or no?
Perfectly.
Yeah.
Okay, perfect. So basically, we started our program after how Anne has her program in Colorado. And we went and talked to the head of the birthing center at our hospital. We're a small rural hospital as well. And just basically put it on the part of these women with cesareans are undergoing major abdominal surgery. We see our major abdominal surgery patients on the acute care setting all the time. So we talked to her, she went to the physicians, got buy-in there, and we teach our women obviously how to get in and out of bed, teach them the log roll, which we had one therapist I knew, her friend had delivered cesarean before we started our program. And she's like, can you help me get out of bed? And I was like, can you please just have her ask the nurse? Let's see what happens, see what they do. And the response was awful. The nurse was like, well, sometimes it works, sometimes it doesn't. You just have to figure it out, which kind of solidified why we needed to be down there. So we go down there, we teach women log roll, we teach them how to contract their transverse abdominis, we teach them how to contract their pelvic floor, breathing, posture. I talk to them about scar massage, simulate it for them on their arm, teach them some gentle pec stretches just because everyone's tight, and get them moving. And the thing is that us getting down there and doing this has led to us seeing women with other, unfortunate complications, like if they've had a pelvic separation, or we recently had somebody with a nerve injury, but also got us down there with lacerations. And when I first went down there, I didn't know what to do with the lacerations. I looked up stuff from the APTA courses I took, and now we see those women too. And that way we're getting them directly referred to the pelvic PT afterwards. So it's really important that this starts out that 0 to 2 weeks that you're talking about. All the things we talked about is what we can start in acute care. And I don't think it's as hard as we think to get that program going. You just have to find that one person to support you, and then it'll kind of snowball. And the nurses, they will even consult us if a woman is down there for a total abdominal hysterectomy. We get consulted on those women because they already see what we do, and they know, and they advocate for our services.
I love it. Wow. Thank you so much for sharing. Thank you, Beth.
Yeah.
Yeah. I am so sad that this is coming to an end. I could Grania, I could talk to you probably for another hour about this.
I know. I was like, I haven't even got to see the chat box. You know, when you're just like, I was like, when you're presenting nothing, I'm like, I'm dying to see the chat box.
You can see it. I won't keep you from it. It'll definitely be saved. And any questions that came in, we'll answer them, in our groups, and get this video out to people who are going to see it later. But just to kind of tie in with what Beth was saying, what Stacey was saying, and what you and the team from UK, what we've all been talking about today is there's individualized care approaches to really get someone from point A, 0 weeks, 0 hours at the time of delivery, back to really running, and kind of like dismantle this belief that we have to do a one-size-fit-all approach. That's not evidence-based at all. I would say that's actually non-evidence-based to think that we have to do this one protocol that fits a wide, extremely variable population, especially when their identity is so tied in with their prior level of function. As an athlete, I'm going to have a battery of tests that really fit me or specific to what I was doing, to prepare me back to that specific activity I want to go back to. So to bring this full circle, I can't thank you enough for bringing such a dynamic team together and having such an awesome conversation again.
Oh, I could talk to you all day, Rebecca. Sure, we always finish this and go, we have more to say. We need to do another one. There needs to be a part 3.
I think that we're going to be doing this on a semi-annual basis, if you're okay with that.
Yeah, I'm totally happy with that. I think I actually think it'd be so funny in like 5 years' time to look back at the first one and see how things have changed, because hopefully things have changed and you'd be like, oh, remember when this was the conversation we had to have because that wasn't taken for granted. And yes.
I agree. I do. I think that there will be a point of time where this conversation, it will be obsolete, and I'll be happy when that time comes.
Fantastic. And thank you for all you do. And thank you for navigating all the conversations and everything so well, because you did it effortlessly. So yeah, I kind of left that to you. So thanks very much.
Not a problem. Well, thank you everyone who joined us for today. This was part 2 of 4th trimester care around the world. I was absolutely tremendously excited to have such a wonderful co-host in Grania Donnelly, and having her share her work and her research and just her presence. I think that I'm looking forward so much more to the impact that we're all making on maternal health around the world. So thank you all for joining us, and we hope to see you soon.
Thank you.